Parasitic infection of the lung. A. Focal lung lesion. Hydatid cyst, paragonimiasis, and amoebiasis. B. Diffuse lung lesions. Ascaris lumbricoides, hookworms, toxocara, schistosoma, strongyloides circularis, and tropical pulmonary eosinophilia. Conditions presenting with focal lung lesions. Cystic lung lesion. Hydatidosis. Hydatid disease is caused by larvae of Echinococcus granulosa, ductive worms, which has a worldwide distribution. Mode of infection. Ingestion of the eggs through contaminated food. Presentation. Lung cysts may present with chest pain, cough, hemoptysis, or pneumothorax. A hypersensitivity reaction may also occur if antigenic material is released from the cyst. Imaging features. Cysts can be seen as a single or multiple well-defined homogeneous lesions. Pneumothorax, pleural effusion, or hydropneumothorax. Chest X-ray showing a hydatid cyst in the left lower lobe. Laboratory diagnosis. Peripheral blood show eosinophilia, which may be found in 50% of cases. Serological tests. Aspiration and microscopic examination. Number 2. Consolidation or pleural effusion. 1. Paragonimiasis. Pulmonary paragonimiasis is most frequently seen in Southeast Asia but also occurs in Central Africa and South America. It's caused by lung flu called Paragonimus westermani. The adult worms are found in pulmonary cysts, usually in pairs. Adult worms produce eggs which are secreted in sputum or feces. Mode of infection. Humans are usually infected by eating second intermediate host, freshwater crab or crayfish, if raw or lightly cooked. Presentation. Presenting symptoms include pleuritic chest pain, hemoptysis, chronic cough, and fever. Imaging features. Radiographic features of paragonimiasis include patchy airspace consolidation, cystic changes, pleural effusions, and pneumothorax may occur. Laboratory diagnosis. Peripheral blood eosinophilia. The identification of the characteristic operculated eggs in feces and sputum. 2. Amoebiasis. Amoebiasis is caused by Entamoeba histolytica, a protozoan found worldwide. Mode of infection. Fecal oral transmission. Presentation. Cough, pleuritic pain, dyspnea, and right upper quadrant pain. A hepatobronchial fistula leading to expectoration of anchovy sauce-like virulent sputum. Radiographic features. Common radiological features include right pleural effusion and basal lung disease. Right lower lobe consolidation may be developed, which may progress to abscess formation. Empyema, hepatobronchial fistula. Laboratory investigation. If symptoms of dysentery are present, freshly passed stool should be examined for amoebic trophozoites. Trophozoites are seldom found in sputum or pleural fluid or abscess aspirate. Serological tests. Conditions presenting with diffuse lung disease. 1. Transient pulmonary infiltrate. 1. Ascariasis. Ascariasis is caused by Ascaris lumbricoides, the round worm. It's common worldwide in areas with poor sanitation. Mode of infection. Ingestion of mature eggs through contaminated food or drink. Presentation. During the second week of infection, Loeffler syndrome is caused by larval migration into the alveoli, which triggers an allergic response leading to respiratory symptoms including cough, wheeze, dyspnea, chest pain, fever, and hemoptysis. Imaging features. During pulmonary migration, transient nodular or diffuse pulmonary infiltrates on the chest X-ray. Chronic eosinophilic pneumonia has been associated with ascariasis of the lung. Laboratory diagnosis. Peripheral blood eosinophilia are often present, and total serum IgE may be elevated. Eosinophils and larvae may be found in sputum. The diagnosis is confirmed by finding characteristic Ascaris eggs in stool on microscope. Number 2. Hookworm infection. Ankylostomiasis is common in tropical and subtropical countries, caused by two species of hookworm, Ankylostoma duodenale and Necator americanus. The mode of infection: penetration of the skin by filariform larvae. Presentation: loeffler syndrome, including dry cough with dyspnea and fever. Imaging features: transient nodular or diffuse pulmonary infiltrates on chest X-ray. Laboratory diagnosis: peripheral blood eosinophilia, and finding the eggs in the stool supports the diagnosis. Toxocariasis. Human toxocariasis is usually caused by the dog roundworm Toxocara canis. Mode of infection: ingestion of the egg. Presentation: most infections occur in children, and most are asymptomatic. Patients may present with immunologically mediated symptoms, including cough, dyspnea, and wheeze, which may present as asthma or bronchitis. Presenting signs may include hepatomegaly, splenomegaly, and ocular lesions. Radiographic features. Radiological features may include transient localized changes or widespread patchy areas of consolidation. Laboratory diagnosis: visceral larva migrans is characterized by persistent peripheral eosinophilia and leukocytosis. Eosinophilia in bronchoalveolar lavage. Serological tests. Number 2. Alveolar or interstitial changes. Schistosomiasis. There are three main species of schistosomes: Schistosoma mansoni, Schistosoma hematobium, and Schistosoma japonica. The adult trematode worms are found in the vesical plexus, as in Schistosoma hematobium, or in the mesenteric veins, as in Schistosoma mansoni and Schistosoma japonica. Mode of infection: skin penetration by cercaric. Presentation: acute schistosomiasis, Katayama fever, may present with fever, cough, dyspnea, rash, and arthralgia. In chronic stage, the commonest symptoms are dyspnea and chest pain. Clinical signs: in severe hypoxemia, digital clubbing may be seen due to pulmonary hypertension. Radiological features: acute pulmonary schistosomiasis show transient reticulonodular changes on the chest X-ray. In chronic lung disease, interstitial or granulomatous changes are caused by the widespread deposition of the egg in pulmonary vasculature. Laboratory investigation: acute schistosomiasis show peripheral blood eosinophilia, finding eggs in the bronchoalveolar lavage or sputum. In chronic schistosomiasis, eggs of Schistosoma species may be found in feces, urine after 6 weeks. Serological tests show IgG antibodies of Schistosoma X antigen are detectable 6 to 12 weeks following infection and can be measured by ELISA. Strongyloidiasis. Strongyloidiasis is caused by the nematode Strongyloides cercoralis and is prevalent in tropical and subtropical countries. Mode of infection: penetration of the skin by filariform larvae. Presentation: in the immunocompromised patient, including those on steroid therapy, a hyperinfection syndrome can result in severe disseminated infection. Symptoms and site consistent with adult respiratory distress syndrome. Extensive intra-alveolar hemorrhage has been reported and should be considered as a cause of acute deterioration. Radiological findings: in strongyloids hyperinfection, pulmonary infiltrates are the most frequent features seen on chest X-ray. Radiographic changes may include miliary nodules, reticular opacities, and airspace opacities ranging from multifocal to lobar distribution. Laboratory investigations: blood eosinophilia. A definitive diagnosis is made by demonstration of a pisiform larvae in stool, sputum, or duodenal aspirate. Filariform larvae may be also seen. Serological tests. Tropical pulmonary eosinophilia. Presentation. Tropical pulmonary eosinophilia typically result from hypersensitivity reaction to the lymphatic filarial parasite, Bushraria bancroftii and Brugia malari, found in endemic regions of Southeast Asia and Africa. It's thought to be an immunological response to microfilariae. Clinically, tropical pulmonary eosinophilia typically has slow onset over several months, with respiratory symptoms including cough, dyspnea, and wheeze, which may be worse at night. Systemic features including fever, malaise, and weight loss may occur. Radiological findings. Bilateral fine nodular or reticulonodular shadowing and mediastinal lymphadenopathy. Laboratory investigation. High titer of antifilarial antibodies. Peripheral blood eosinophilia. No microfilaria in blood. Total serum IgE is raised. Thank you.